Good afternoon. We're delighted to see all of you here today. We have a really good program planned for you. I'm going to introduce Becky Dawson, who is the director of the Northeast AHEC Regional Office that serves 20 counties in this area, 21 counties, I guess, in this Northeast Missouri area. She is the coordinator for the HPV project that she's going to talk about just a couple minutes more. But we are delighted to have Becky helping with this project all over Missouri. And we're delighted to have the panel today. And so I'm going to turn it over to Becky to do a little bit of background for you, and then we'll turn it over to the panel.
Thank you. I just want to mention a couple of things about this project, the HPV project. The National AHEC organization has received funding from the Centers for Disease Control and Prevention to provide provider education across the country to improve the immunization rates for preteens in terms of the HPV immunization. So the main objectives that we have for the program nationwide is to provide clinical outreach and training. We also disseminate educational materials. And one of the things that you have or will receive are some handouts regarding HPV immunizations, and that was sent electronically today. So you should have that as a reference, and feel free to print those off or to share those, because that will help your understanding of what the situation is. Another thing that we do is to form partnerships across the country to promote the whole idea of preventing cancer through HPV immunizations. And finally, we want to raise the level of awareness so that more people are aware that this is something that can be prevented in terms of certain types of cancer. And we hope that this information will be of interest to you. One of the things that you received is a feedback form on the yellow sheet, and that will give us some feedback from you as health professional students so that we can provide more thorough information for those in the future. We really appreciate our panel today. I will introduce our moderator, Dr. Campbell. Just briefly, Dr. Campbell graduated from here at AT Still, KCOM, and he joined ATSU in January of 2014 to serve as the Associate Dean for Academic and Clinical Educational Affairs here. Prior to coming to ATSU, he practiced primary care for 30 years in the St. Louis area, and he would be one of our experts in terms of practicing primary care with the families. In addition, he has served on numerous committees and boards, and most recently as the president of DePaul Medical Group in St. Louis, and as a member of the KOAA Alumni Board from 2009 to 14 before coming to Kirksville. So we welcome Dr. Campbell, and we appreciate you coming.
Thank you. I'm not going to wear this because...
Okay, you can.
Well, maybe I will. I'm going to be quite brief. So when Jan and I were meeting one time, and she asked me what I thought about HPV vaccine, and I said, I think everybody ought to have it. And she asked me, so would I speak to a group or at least be the moderator? And I said, heck yes, probably, didn't I? Is that what I said? I said something yes. And she asked me why, and I said, I'm a huge advocate of HPV vaccine, and I'll tell you guys why. So I've started practicing before the statins were even available, and they came out with all these statin studies, and they said, you know, we're going to save lives. We're going to save lives with statins. And, you know, I always wondered what they meant by saving lives, because I think you can't really do that. You can postpone the inevitable, you can prolong lives, but you don't really save lives. And same thing with cancer. They said, oh, you know, certain behaviors can reduce your risk of getting cancer. Smoking certainly increases your risk of getting cancer, correct? But I don't know that not smoking necessarily reduces your risk compared to the rest of the population. But for 30 plus years, I preached to people, well, not 30 plus years because HPV wasn't available, but I said, you know, there are two ways to truly prevent cancer. And I think these are different than anything else for me. Colonoscopy. By doing screening colonoscopies, not every polyp becomes malignant, but I guarantee you every colon cancer starts out as a polyp. So every time you remove a polyp, you have potentially prevented cancer. The same thing with HPV. You know, you do not get cervical cancer if you're not infected with HPV, or at least that's still the current thinking, right? I mean, and so if we have a vaccine that will guard individuals from getting both cervical cancer and genital warts, why wouldn't we use it on each and every person? Of course, there was always pushback from the parents. You know, you're advocating children to be sexually active more frequently or sooner. Your vaccines have all kinds of side effects, et cetera. And I told them, you know, interesting, but I just don't agree with that. I think the more people you vaccinate, the better. I mean, we're trying to stamp out hepatitis B across the globe, and we're getting there. Certainly, we have done a great job with, say, smallpox, and although recently that's not necessarily true, but there's a few isolated outbreaks. But really, vaccines do a great job. So that's why I'm such a huge proponent of the HPV vaccine. I'm not the expert; these guys are. Let me introduce them to you. First, Melody Stocks. She's a OBGYN here in town. She's on our faculty, and I think she'll do a wonderful job. Lori Guffey, who I probably shouldn't tell him I've known you since college, but for a long time. She does a wonderful job for the health department here in town. And Shaquila Matthew, who is a pediatrician. They're both, I think you're each going to say a few words, correct? My understanding is none of them have any financial disclosures. And these are the objectives to make sure everyone understands the importance of HPV vaccination for cancer. Again, prevention. We keep talking about cancer prevention, but truly I think removing colon polyps and giving people HPV vaccine are the two ways you can truly prevent cancer proactively, not just avoiding behaviors or actions that reduce your risk, but actually trying to prevent cancers from happening. Why we both vaccinate girls and the vector, the boys. Somebody will be talking about that. Useful and compelling information about the vaccine itself so that you can help mothers understand why, or parents, why it's so important to utilize these vaccines, and also give you information that will help you explain the importance of this, and also you can share with your patients to hopefully help them understand why this vaccine is so important. Okay? So I think we'll start with Dr. Stocks. Thank you for your attendance today.
Thank you. All right, I'm an OB-GYN and work with the Health Council with Shaquila, and I've been in Kirksville for 3 years. HPV is something that I deal with, not personally, but on a professional level, 5 days a week, every week, and multiple times a day. So basically, the part I'm going to talk about is just the burden of disease, which, like I said, is a daily thing for our practice. Most females and males will be infected with HPV at some point in their life. I usually quote people an 80% chance, just because studies do suggest that. So I say, 80% of the time, 80% of people are going to get HPV. If you look at everybody in this room, some of you have it. Then 80% of those people probably don't know that they have it, and 80% of the time it's going to go away. We don't have to worry about it. But it doesn't always. Just the numbers, you can read them. 79 million Americans are currently infected. There's millions and millions of new infections every year. And it's most common in the teens and early 20s, which is the population that I discuss this with the most commonly. But I will tell you, I see 70-year-old women that get positive HPV tests every month. So, like I said, most people don't know that they have it, just like herpes. They're just out there spreading it around. New cancers caused by HPV, the most common one is cervical cancer, but it is not the only cancer, and men are not immune to getting cancer from HPV-related diseases. The ones that I mentioned most commonly to my females is your male partner is at risk for oropharynx cancer, as are women. I've had a woman as young as 27 with tongue cancer related to HPV disease and smoking, and she had quit smoking at 25. So it's not something that women are immune to either. The cervical cancer is the biggest burden disease, and the numbers always shock me at how few women have cervical cancer, because in my career, I see it. So even if you only have 10,000 cancers, there's 3 or 4 of those in Kirksville. Most commonly, though, are what we see are the HPV-related burden of disease, the precancer, the dysplasia, the genital warts, and enormous. It's, like I said, it's a daily thing for us. And I always sit there and think, this didn't have to happen, especially genital warts. The coverage is so good for that. But people choose not to vaccinate or just were unaware of it. The other thing that I noticed this slide didn't mention that I personally feel is, and I see so commonly, is the psychological burden of disease. Telling a patient that they have a sexually transmitted infection and that they're gonna have to go tell their partner is huge. They hate it. It's massive in their psyche that they have this problem and that they have to deal with it, and dealing with the genital warts. And you know what, they might go away on their own, but anything else that we do to get those to go away is going to hurt a lot. And just, that's not even addressed, but you can prevent that with a vaccine. And I try to explain that to my patients. The HPV is cancer prevention, and it does prevent a lot more than that. So there's secondary effects, but that is the primary thing we're trying to prevent is cancer. The recommendation is for both males and females. You can start as early as 9, although typically they start in the preteens, 11 to 12, with some of the other vaccinations. The vaccine is given over a series of 6 months, so there isn't any reason why you can't finish by their 13th birthday. Although I don't see typically children that young, and I see people all the time, women that have not finished their vaccine series. The 13 to 26-year-old, and my population is probably more 16 and over, but we see women, we start the vaccine. You can start the vaccine at age 26, and they can finish it when they're 27. So we'll start them right up to the month before they turn 27. Boys, it's age 13 to 21. They don't get quite as long of time to get their vaccines. The vaccine type, so recently they came out with a 9-valent HPV vaccine. We've just had this arrive in our office within the last few weeks, so it is still new. The quadrivalent is what we had given for years, and that covered both the 6 and 11, which cause your genital warts, as well as the 16 to 18, which is where the cancers are more concerned. The 9-valent has increased the protection for cancer. So we are transitioning over to 9-valent in our office. The bivalent, this came out when I was a resident. The different HPV vaccines was quite controversial. Bivalent, as far as I'm aware, has never really been widely used in the United States. The vaccine recommendations, again, starting through age 26 for females and through age 21 for males. There is some differences for men who have sex with men and immunocompromised patients, so men can get it a little bit later. And they also specifically recommend the quadrivalent and 9-valent only for males. Again, I don't really find this really that important because I don't know where you can get a bivalent vaccine. The other thing that a lot of people are asking this question, there's 2 big questions I get because of where I'm at in practice, where a lot of people maybe when they were 13 got 2 of their vaccines, but not the third one, is do we have to start our series over? What if I got the quadrivalent? Can I get the 9-valent? And basically they recommend that for females, any of the HPV vaccines can be used to complete the series. And for the male, again, I don't know where they could get the bivalent anyway, so essentially, yes, you can finish it with whatever is out there. Generally, we dose ours about 2 months apart from the first to the second, and then 4 months later, it kind of goes along with the Hep B type series. This said 6 weeks, so that's an option. 1 to 2 months, vaccines aren't as particular as parents think they have to be exact. And then again, probably the biggest question I get is if I haven't finished the series, do I have to start over? And the answer is no. It doesn't matter how many years have lapsed. And I honestly don't confirm. If they say I've had 2, I don't know if I got the third one or not, I just give them the third one. So I would rather know for sure that they got all 3 of them. So I do, we do a lot of giving that last final shot or the last 2 shots in our office. Nora, you're up.
Hello, everybody. I'm Lori Guffey, and I'm from the Adair County Health Department. I am the clinic supervisor there. And we offer a variety of vaccines, but one of them that we do offer is the HPV vaccine. I'm going to talk about the HPV vaccine safety. Vaccine efficacy is the ability of a vaccine to work as intended to protect from illness, and the vaccine-associated risk is probability increased adverse event that harm the individuals or population. The VAERS HPV vaccine safety monitoring. VAERS is Vaccine Adverse Effects Reporting System. The ongoing safety monitoring has shown most reports are non-serious. Among the 7.6% of reports coded as serious, most frequently cited possible side effects are headache, nausea, vomiting, and fever. Syncope or fainting continues to be reported following vaccination among adolescents. And, basically after they receive the vaccine, we always ask them, do you feel funny? Have you passed out before? And we usually have them sit for 10 to 15 minutes after they get the vaccine. Most of our complaints at the health department is the vaccine. It burns. The vaccine burns when it's administered, but usually nobody has, we've not heard of any problem with it, so. The 9-valent HPV vaccine safety, there's been 7 pre-licensure studies among 15,000 males and females, generally well tolerated. Adverse event profile similar to that of the 4-valent HPV across age, gender, race, and ethnicity. More injection site reactions are expected among those who receive the 9-valent, and we get that complaint all the time that it just burns, so. This is the HPV vaccine impact, monitoring the impact of the vaccine programs and the associated outcomes. You can see the early outcomes, years, is the HPV prevalence with genital warts, and then the mid outcomes, years to decades, with precancers, and late outcomes, the HPV-associated cancers. HPV vaccine impact monitoring, these are studies that have been done. The population impact against early and mid outcomes have been reported. You can see the genital warts has been reported in Australia, New Zealand, Denmark, Sweden, Germany, Quebec, and the US. The prevalence of HPV in Australia and Norway and Denmark and Sweden, the United Kingdom and the US, and then cervical lesions. The HPV, the vaccine, the duration of the immunity, the studies say that the protection is long-lasting. There's no waning of immunity. Available evidence indicates protection for at least 8 to 10 years, so that's pretty good. Multiple cohort studies are in progress to monitor the duration of immunity. You can see here that the HPV vaccine coverage in Australia is 71.2% among girls in high-income countries with 3 doses. The United Kingdom, it's 60.4%, and the United States, it's 33.4%, so that's low. Adolescent vaccination coverage, United States, 2006 to 2014. You can see on this one that the Tdap, which is tetanus, diphtheria, and pertussis, and Menactra, that's high, but the HPV in the girls and the boys, that's significantly low. This is the table on the impact of eliminating missed opportunities by age 13 years in girls born in 2000. 1 dose they were given at 47%, but this indicates that 91% is achievable. Thank you.
Okay, good afternoon. I'm Shaquila Matthew, pediatrician in Kirksville, Missouri. So what we're going to do here is we're going to try to talk about how to frame a conversation with the parent to recommend HPV vaccine. So if you look at this graph over here, you can see that pretty much a parent looks at all the vaccinations pretty much equally, meningitis, hepatitis, HPV, but the physicians don't see it the same. The physician kind of underestimate the value the parents place on HPV vaccine. So we do recommend that during every clinic visit, or at least during their adolescent visit, that we recommend the HPV vaccine. And a strong recommendation from a physician usually ends up, the parents end up saying, we'll vaccinate our kid. It's kind of like recently I had a patient 2 weeks ago, a 9-month-old who came in, and we said we would recommend the flu vaccine, and the parent immediately asked, would you recommend it for your child? I said yes. And it's the same as that. If it's 11 or 12-year-old, if we as a physician say we would recommend for our kids, or, you know, we would recommend it, they would usually say yes unless they have something really against the vaccine. So what do you have to do? When 12-year-old comes for a clinic visit, they're going to get 3 shots. So usually they get the Tdap, meningococcal, and the HPV vaccine. So what you should do is you should just kind of talk to the parents and say, we're going to give you 3 shots today, and that's going to prevent against pertussis, meningitis, and cancer. And usually it works out. And this kind of sentence says, Sophia is due for her 3 vaccines today. This will protect her from meningitis, HPV, and pertussis. We'll give the shots at the end of the visit. Now, when you say this, the first question the parents are going to say is, why does my child need this vaccine, which is usually HPV, because they're used to getting the Tdap and they don't have any issues with it. So your answer is going to be, it's going to prevent against cancer. And usually that helps parents understand the importance of HPV. Now, the next question is, my daughter is not sexually active. She's only 11, 12 years old. Can't we just wait until she's married or starts getting sexually active? And so the recommendation is to start earlier to prevent HPV, because what if she waits until she gets married and marries somebody who already has HPV? Then she's going to get it from them. So we want to start early. Now, then why wait? Why don't we wait until she's 16 or 17 or maybe 20 or 20 or 25, like Dr. Stotts was saying? So the HPV vaccine has a better, robust immune response when given in preteens rather than when they're older. So that's why we recommend giving it a little bit earlier. So would you give it to your child? Yes, I would. And let's say if you're a physician and you don't have a child, you just need to say, I would recommend it for any family member that I know, or any close, or a child or a grandchild. And the side effects is another concern the parents have. We've already discussed, Lori talked about the side effects that vaccine can have, but the most common side effect is just pain at that injection site, which is with any other shot, like even when you get Tdap or when you get the flu shot, you're gonna get pain at that site. So just kind of say that, and we always monitor our patients in clinic 15 to 20 minutes. I know she said 10 to 15 minutes, just to make sure they don't have any fainting spells right when they leave the clinic, because that's one of the reported side effects. And so once they get the shots, you're going to send them home, and they need to come back for the 2 other shots. So what we try to do in our clinic is we tell them to go outside, make a follow-up appointment, a nurse visit, a month or 2 months from now. So that way they have that in place and they don't forget, because it's so easy to forget once you go home that you need to get another 2 shots to complete the series. Okay? And I think, so the end point is HPV vaccine is cancer prevention. And so we recommend that for all adolescents between 11 and 12 years to start off then, not wait until they're a little older. Okay? So I'll go back up there, and if you guys have any questions, we can start getting questions.
Does anyone have any additional comments before we take questions? If not, please feel free to ask questions, and even if you think they might be awkward questions, it's good practice for when you do this out in practice. You're going to have to talk to people and ask them questions you wouldn't normally discuss with other individuals, but this is good practice to learn how to do that, number one. I would make a couple of comments. I do think that when they ask about the age, I think it's not imperative, but it's best if the vaccine is started before their first sexual encounter, number one. I used the line to a lot of patients for a lot of times. I would do this if this was my mother, my sister, my daughter, my wife, et cetera, throughout my years of practice. Actually, when the vaccine did come about, we gave it to our daughter. We had our daughter get it. She told me repeatedly that she didn't need the vaccine. Don't worry about it, Dad. I don't need it. It's not a problem. I said, well, what if something bad happened to you? You're going to get the vaccine. And so I do think that's a great way to frame it, that, hey, I would give it to my family, or I would get it myself if I was in the right age group, et cetera. And when people hear cancer, suddenly their auditory system shuts down. So they hear cancer, you get their attention. So if you tell them we're preventing cancer, like I said earlier, I do think it has a huge impact. So I saw a question.
I just wanted to ask about the duration of immunity. Has the vaccine just not been around long enough for us to know? At our HPV lecture in Women's Health this week, they mentioned 5 years. On the slide it said 8 to 10. Just curious.
The studies that have been done of the quadrivalent and bivalent vaccines, they're still following those groups of people. So at this point, I think that's the case. Like, they know that 8 to 10 years is okay, but it's just not been out long enough to know the length beyond that if 30 years from now it's going to make a difference.
I guess my question, and you probably won't know the answer, because I think it might just not, you might not have information that far out yet, but I'm wondering if they have seen any cases of people, of women that have gotten the vaccine and are presenting with HPV. Or is I know there's other strains beyond the ones that vaccines cover, so that's obviously probably part of it.
Would you guys repeat the question?
Sure. She was asking if we see cases of HPV in patients who have already been vaccinated, prior to, and then they come in later with HPV. I see that all the time. So, for various reasons, there's over 30 strands of HPV that infect a human. So actually it's 100 strands. There's 30 that affect genitally, yeah.
Mm-hmm.
So 30 that even just for the genital tract. So I will see patients, and I've seen, there are 2 different reasons. I think one, sometimes the sexual activity has occurred prior to starting the vaccine series, so they may have actually already had the vaccine. And then the second reason is there are other viruses out there. But remember that a lot of HPV does go away on its own, so those aren't the strains that we're necessarily the most worried about. So I'll tell them, you had the vaccine, and I don't know what type of HPV you had, but especially if they had it before they were sexually active, and now you're positive with an HPV test, or you have an abnormal pap smear, so we assume it's from HPV, that there's still a good chance this is going to go away, and it's not going to cause you to have cancer, because we're really wanting to prevent the cancer.
So since there are so many strains of HPV, would you recommend to your patients to get the 9-valent even if they've already started the 4? Would you just switch them over? Or what about people who maybe already finished the quadrivalent series? Would you recommend additional vaccination with the 9-valent?
I don't want to answer the questions.
I would, to the first question, I would say yes. Now that the 9-valent is available, I think you're going to see that being used almost exclusively eventually. Would you agree?
Yeah,
Our
well,
Peds clinic just started getting the 9-valent.
Yeah,
but
I
we're still doing
yeah,
the
I don't know that there's any data that would support vaccinating someone who's had the quadrivalent injection already have the 9-valent. Realize that, and you'll know more than I do, but 70 or 75% of cervical cancers are caused by 16 and 18, and they're covered. I would also tell you, years ago when somebody came with if we got an abnormal pap smear back, we treated them very aggressively.
Mm-hmm.
Now it's kind of hands off. Let's wait and see if it resolves on its own, and a lot of them do. So I don't know that we would be as aggressive, or you would have to treat somebody if somebody's already completed the 4-valent, the quadrivalent series. I don't know that it would be appropriate to give them a 9. I don't think we know enough.
yeah. It's not
about that.
recommended now
Yeah.
at this point, and they
But-
wouldn't pay for it either.
Yeah.
People get stuck with their.
And again, my point earlier was so many of them resolve on their own too, that I don't know that there's any data that would support that yet. We'll see when we get enough history of people who started with the quadrivalent and switched to the 9-valent. If we see, if they're divergent, those populations diverge, then we'll probably start saying, hey, maybe we should do this.
A booster or something.
Yeah.
I could see that happening.
Kind of like we're seeing with Pneumovax, and
Exactly.
we're seeing that, hey, even if you received Pneumovax, or no, which one? Yeah, Pneumovax. you get.
Pneumovax, and then they
If-
have the Prevnar.
And then you got Prevnar, or if you receive Prevnar at 50, you should still get Pneumovax at 65. That's what we're seeing. Somebody else had a question.
Mine is regarding, you kind of going back to what you said, do you have any recommendations this time regarding booster or re-immunization? If somebody received the vaccine at 11 and now they're 23 or 24, would they be eligible for, or is there anything in the works that suggests?
Not that I'm aware of.
Not that
right
I
now.
know of either. Mm-mm.
Hopefully we'll reduce the disease load enough by then that.
Why is the upper limit for women 26?
It's a great question. So part of it has to do with the study population and being approved through the FDA. That's what it's approved through. And the second reason is a lot of times, just in sexually transmitted diseases in general, 25, 26 tends to be the age at which, it depends on which society you look into, but you may not necessarily need to do routine STD screening. A lot of women have kind of settled down at that time and are not changing partners as frequently. So that it's just become kind of this bizarre like standard that was set. I can't answer there was the exact reason, but part of it is just the study population.
So if we do find that doing a booster shot with a 9-valent for people who have already finished their quadrivalent is a good idea, would that be available for people over 26?
I have no idea. I mean, I'd like to vaccinate some of my patients that are over 26, but it's not an option. So at this point, I don't know.
And I don't think insurance covers it.
Yeah,
No,
they certainly wouldn't pay for
Insurance
it.
doesn't cover.
I mean, just as residents, we tried to get the, I didn't care as much, but one of our residents tried to get our faculty to allow them to be vaccinated because we're exposed to HPV all the time. Just with like LEEP procedures and stuff like that, aerosolized, I mean, OB-GYNs get HPV from their patients, unfortunately. And they said, no, you can't do that. But she had a legitimate concern. And one of the research projects that I propose is we actually screen all of our like nasal swab, screen all your interns that come in. And then when you're out, how many of us actually have HPV in
But
our
they didn't wanna know-
oropharynx
you
and
didn't
stuff.
wanna know the results.
We don't want to know that. But I mean, it's a legitimate, and we're over 26, we can't get it, because I was too old, when it came out. But it's not an option unless you want to pay the, I don't know, is it $100, $300?
Yeah, it's
It's
130
expensive.
or something. It's expensive.
Each vaccine,
For
each shot.
Each shot.
Right. I knew it was over $300 to get the full series. And you're poor when you're a medical student or a resident.
They all agree. I don't know. I mean, I don't know if you could get in trouble for giving it to somebody 26 right now. If somebody, I mean, I guess if you asked for it. But anyway.
I'm not sure.
It's not, that's a moot point at this time.
Given the difference between other countries and the United States on the rate of vaccination, do you have any ideas why that may be? I mean, it looks like a lot of other countries in the research are farther ahead in terms of percent population vaccinated. Why aren't we there?
I would take a guess, well, go ahead.
I would just think, I think it's just very important to talk to your patients, to try to educate them as much as possible. And I think a lot of the people that, we deal with, I think they, when you offer that to them, it's like you're giving their children a green light to be sexually active. And I just think it's all about talking to them and educating them that that's certainly not the case. And,
Yeah, I think, number one, access. There's a lot more access in other countries where everyone has access to getting vaccines compared to this country. Number two, there's a lot of press about people very concerned about the side effects from vaccinations, and there's a lot of people say this. And then I think other countries, they're probably more open about their sexual activity, even at younger ages than they are in this country. So those would probably be the three biggest reasons, I would say. And like Lori said, I think those are probably three huge reasons. And I don't think that it promotes sexual activity at a younger age, but that's the pushback you'll get from parents.
I'll also say that since I see a lot of the older, like over 19, so they can't get the vaccine through the Vaccines for Children program, that a lot of those patients actually don't have coverage for the HPV vaccine. So between 19 and 26, actually getting coverage, it isn't always covered on insurance programs. You would think that it would be as preventative primary care, but it's not. So we actually, and if the, say that age group doesn't carry their parents' insurance or they just don't have insurance necessarily, we do have a program in our office that's through Merck that we can give the vaccine to that group of patients free. We do have to fill out a lot of paperwork, but we give it to everyone, whether they can afford it or not. We give it to everyone, but that is not the case outside of that. And I don't know at the health department you run into a problem in that age group.
We do. We do have a program through the state that we would be able to, we don't do it very often, so we would have to order it to give it to those that, are over 19 and their insurance will not cover it. It's through a 317 program while the funding lasts. It's always while the funding lasts. So we do have some of those programs available.
And most of our peds patient decline vaccines, the HPV, is mostly because of parents are worried. That means they're saying okay to the kid being sexually active. And the ones that come in saying that they want the HPV, either the parents are worried that the kid's already sexually active, or they're going to be sexually active because the kid has a boyfriend or something like that. But I think educating at least earlier, like at 10, 11, kind of educating them, so giving them a heads up, it's recommended to get it, would help, I think.
And I see a little different population of moms who bring their daughters in to get vaccinated because I just saw the mom for an HPV-related disease. And they'll bring their girls and you're not going through what I just did.
And that would be another thing, like, if parents decline the vaccine, if you know any family member with HPV, giving the vaccination would prevent it, and that would at least kind of let them think about it as a cancer prevention rather than to let their kid be sexually active.
I see a question.
I guess more from like a pediatric standpoint, but like when you do have a case like that where like the kid kind of comes in, like at 11 or 12, like wanting to get vaccinated, and the parents like really confused, like how do you deal with that as a provider? Like do you talk to them separately? Like I feel like it gets
We do talk to them separately and then talk to parents as to what concerns you have. But usually if a kid says they want the vaccine, the parent is okay with it. It usually is the other way around where the parent is like, I want the kid vaccinated, and the kid's like, I don't want a shot today, and it's pretty much because of pain and they don't know much about HPV or flu, whatever shot it is, they don't want it. So mostly if the parent says yes, the kid gets the shot. And we explain as to why it's important and things like that.
Do you find a difference between parents of boys and girls at 13 or at the younger ages, whether or not they're willing to get the vaccine?
Before it used to be a concern. Now that it's a little bit more open about HPV in boys and girls, I think parents are a lot more open that, you know what, boys need to get it too.
I do too.
But prior to that, it used to be like HPV only for girls, and now it's changed a lot. So
We've seen more for boys than we used to at the health department.
within the last year or two,
Yes, I would
we've
say.
noticed a lot of difference.
Has coverage, I guess it said 21 was kind of the max age for boys to use, I guess, I don't know.
Well, I don't
family
see it, but
care-wise.
do you?
Would you
For
guys
you
say-
and help.
We go up to, like Dr. Stark, to 26, and, if they want to start it at 26, they certainly can, and we can finish them up.
Do you do to boys after 21?
Do we?
Do you see guys come in?
Yes,
Do you?
we do. We do.
I don't see guys ever.
We do. Not a lot, but, some.
I did think of another question that the slides didn't address, but I get a lot is patients who already have HPV. So I'll have like a 22-year-old student or 19-year-old college student come in and they have genital warts or have had 25 and an abnormal pap, and they'll ask whether or not they should still get the HPV vaccine, and the answer is yes, but it's a very common misconception. So a lot of times they feel if they already have HPV, they want the vaccine because they want the vaccine to make it go away, which is not going to happen. But I get asked that a lot. And then the other thing is they assume that once they have HPV, the vaccine won't do them any good, and that's not necessarily true either. But I get that from both parents, and used to when we did pap smears on a lot younger girls, that was even bigger question because they already had an abnormal pap and they were 17 years old, since we don't do paps that young. I don't see it quite as much in that age group, but certainly in the college student age group, I get that question a lot. But they do recommend that you still get the HPV vaccine if you haven't been vaccinated, but you already have HPV, because it's very unlikely that you've been exposed to all forms of HPV in the vaccine, so it still may prevent a future exposure to a future strain of HPV.
Okay, any other questions? Those are all great questions. You know, I would just say in closing, you know, when people ask you, why would you do this? I would tell them, why wouldn't you? You know, here you have an opportunity to prevent either cancer in this individual or the vector that might give other people cancer. Why wouldn't you? And rarely do they have a rebuttal to that. So I would continue to promote this vaccine. I can't think of a reason why you wouldn't. Otherwise, if there's no other questions, can you give our panelists, give our speakers a round of applause?
Thank you.